Good afternoon, everyone. Welcome, and thank you for joining us today for this seminar, Intersection of Quality Improvement and Implementation Research, Perspectives from U.S. and Global Primary Care Settings. This event is part of our 2022 Institute for Implementation Science seminar series, which features lectures with leading implementation science experts. Recording of our past seminars and registration for our final seminar next week can be found on our website, which we'll put in the chat shortly. We have a few quick announcements before we get started. This seminar is being recorded and live transcription closed captioning is enabled. The recording will be posted to our website after the event. All microphones are muted, so if you have any questions or comments for discussion during the seminar, please enter them into the Q&A box and we'll get to them after the presentations. I'll now hand it over to our Institute co-director, Dr. Maria Fernandez, to introduce our speakers today. Thank you.
Thanks so much, Ricky, and thank you everyone for joining us. I'm very excited to introduce today's topic, which is Intersection of Quality Improvement and Implementation Research, Perspectives from U.S. and Global Primary Care Settings. And we have two phenomenal, globally renowned speakers today, Dr. Bijal Balasubramanian, our co-director of the UT Health Institute for Implementation Science, and Dr. Rohit Ramaswamy, and I'll give a brief introduction to both of them. Dr. Bijal Balasubramanian is the Rockwell Distinguished Chair in Society and Health and Professor of Epidemiology at the UT Health Houston School of Public Health. She's also, as I mentioned, the co-director of the Institute for Implementation Science. She's a primary care physician, an epidemiologist, and health services researcher with expertise in cancer prevention and control, primary care, and dissemination and implementation science. Dr. Balasubramanian's research focuses on developing rigorous mixed methods approaches to implementing and evaluating interventions and understanding the multi-level determinants of suboptimal care quality for patients. She's received funding from the National Cancer Institute, the Agency for Healthcare Research and Quality, the National Heart, Lung, and Blood Institute, and other federal, state, and not-for-profit organizations and foundations. Dr. Rohit Ramaswamy is a professor of pediatrics and co-research director at the James M. Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. Dr. Ramaswamy is a highly respected national and international expert in applying tools and methods of implementation and improvement science to better the quality of public health programs and to strengthen hospital and health service delivery processes. He works in the US and globally, helping facilities and communities learn the tools of applied implementation and continuous quality improvement. Prior to his current position, Dr. Ramaswamy was a professor at the Gilling School of Global Public Health at UNC Chapel Hill, where he developed graduate courses on QI and implementation science that are taught in a variety of universities in the US and abroad. So join me in welcoming Dr. Balasubramanian and Dr. Ramaswamy, and I'll turn it over to you. And Bijal, I think you're on mute. There you go.
Yes, thank you so much, Maria. for that kind introduction. And I will share my screen and get started, and then Dr. Ramaswamy will follow. We will take questions towards the end. Okay, I want to first just confirm that Ricky or Maria, that you see my full screen view.
Looks good.
Okay, great. Thank you so much. So thank you for that kind introduction again, and really for the opportunity to share my thoughts about this topic that has greatly influenced my research over the last couple of decades. I began my career in public health and population health research, very interested in applying the methods I was learning in public health to improve the practice of medicine because of my background as a primary care physician, and was fortunate at the time to be working with a group of primary care clinicians and researchers. This was in the early 2000s, that really had done groundbreaking work in characterizing features of primary care practices that were important to care, things like comprehensiveness and continuity of care. And note that I don't say things like hemoglobin A1C and cancer screening. It really is about the core attributes of primary care. And as researchers, we're working on how to improve primary care practice through implementing quality improvements. And this was sort of the space I grew up in, so that patients receive these really high attributes of high quality primary care. The field of implementation research was also coalescing around that time frame. And so I've been very fortunate to experience both quality improvement and implementation research as it was developing in primary care practice-based research. And in this, for the next several minutes, I hope to share some of my thoughts about it, as well as give a couple of examples from the work that I've done in US primary care settings. So as researchers and practitioners, we have a common goal that our interventions, our practices result in change and ideally improvement over time. To do this, we're forever aiming to strike a balance between the push of research and the pull of practice. And several folks have written about it, and prominently Jennifer Lehman, whose work I've followed. In implementation science, the push of research often begins with a desire to implement an evidence-based intervention or a clinically accepted practice more consistently and with increased uptake. And the premise is that increased uptake of that EBI will result in improved outcomes. To do this, as researchers, we often will select or develop an implementation strategy, right? A strategy is defined as methods or techniques used to enhance adoption, implementation, and sustainability of a clinical program, intervention, or practice. And then we develop a plan and implement that EBI. Finally, we will evaluate how well the EBI was implemented and whether it resulted in improved system or clinical outcomes. That sort of is where the push of research is. Evidence-based intervention that we identify needs to be implemented, and we take it to practice and we try to implement it. However, there is also the pull of practice, right? That model suggests that there's also the pull of practice, which is often determined by what is the local need, right? What is the local challenge? When I say local, I mean, what is the practice need and practice challenge? And to do that, we often have to select strategies that also enhance organizational capacity of that practice while also identifying and implementing an evidence-based intervention. Therefore, there is a need for research to apply a pull model with the goal of building practice level capacity, not just the push of research into practice. I think as researchers, we inherently understand this push and pull dynamic and we want to balance it. However, in the real world research, this is a challenge, and I'll try to exemplify some of those challenges as well. So let's review some key aspects of both fields. Quality improvement as a science and as a practice originated in the industry, has been around for a long time and used in health systems. It's a well-established field. The goal of that field is to change systems. And in recent years, we have seen a lot of initiatives about transforming primary care, transforming health systems as well, to improve care delivery and outcomes. As I said, it is often driven by specific problems that occur in health systems. For example, we want to reduce hospital-acquired infections or reduce readmission rates. I think what is unique about quality improvement is that it is highly local, in that knowledge from quality improvement projects is very applicable to the local context. Implementation science, on the other hand, originated from behavioral sciences and health services research. It focuses on developing approaches guided by theories and frameworks and models to implement evidence-based interventions with the aim of closing the gap between research and practice. And we've heard that a lot. I.e., bring what we know works is evidence-based into real-world practice. It is often driven by an underutilized evidence-based intervention. And the goal, like quality improvement, is also to improve care quality and clinical outcomes, but, or I would say, and importantly, produce generalizable knowledge. And the focus of implementation science often is also on measuring and determining whether implementation resulted in better outcomes, measuring implementation outcomes, and also further, and there's a push for this in the field, to identify mechanisms of change. And it's through that process, through that research, that we can then produce generalizable knowledge. However, I think you will all agree that quality improvement regularly involves implementing evidence, of course, and implementation science is also consistently grappling with and having to and should address organization and system level factors. So there are some commonalities that both fields are also grappling with and working on, albeit coming at it from different areas. And I would say that to some extent, the fields have been siloed, yet there have been examples of how they can work together, and we'll go into that first in US primary care settings. I think to just summarize the background of these two fields that I was trying to set up, it helps to appreciate the pros and cons of these two areas. So as I said, quality improvement is highly local. If done right, implementers are often very motivated and engaged in that local practice change. It often involves small tests of rapid change, like in the form of PDSA cycle, plan, do, study, act. Implementers plan small changes, implement them, study whether the change is improving and changing outcomes, and then act on making it part of routine practice. If the change does not work, it is abandoned and a new change is implemented. This quality improvement is fast, can be nimble, can be less costly because of this rapid and iterative nature of quality improvement, which is its hallmark. Of course, the major downside of quality improvement is that because it is so local, that lessons that are learned from failures, more importantly, I would say, and also from successes, are not systematically evaluated sometimes, and definitely are not documented to benefit other projects and settings. So we have lost knowledge because of the highly local nature of quality improvement. Implementation science, on the other hand, as I said, strives to produce generalizable knowledge, which is its best asset here. It uses theories, frameworks, models to systematically assess contextual factors that are important, and also demonstrate their impact on implementation and effectiveness. The downside is that it takes time. It's slow. It takes years, like any other research project. We also have seen over the years progressively complex implementation strategies and interventions that often, while the goal of implementation science is to bridge practice, research and practice, the complexity of implementation science is sometimes starting to get in the way of achieving that goal. And then also implementation research may not align as well with local context. It may not be completely relevant to the local context. It may not be generalizable to other contexts, sometimes when it becomes very specific to the research that's being done. So there is that balance to be struck. And so in this space, blending the two fields can have important advantages. It can leverage the local context of motivated practitioners and the rapid iterative nature of quality improvement, And it can also produce generalizable knowledge to scale what we learn from and across many of these local settings to the larger setting. I think of it as being able to learn from many micro settings and applying it to the greater whole. But very importantly, the micro settings also benefit from the changes that are implemented along the way. So it isn't that we're using quote unquote practices for research. We want them to be partners with us and benefit from it as well. So that's again the balance we need to try to strike. So there are at least two ways, and perhaps more, in which the benefits of quality improvement can be blended with implementation research, where quality improvement methods or interventions could be an implementation strategy to enhance EBI uptake, but also can be used to build practice capacity. And I'll try to describe two examples where we have done this and blending quality improvement implementation science to build practice capacity as well as as an implementation strategy to enhance EBI uptake. So the first example is the Evidence Now initiative. And within that, the initiative was focused on cardiovascular disease delivery practices. But within that, for illustration's sake, I'm going to focus on one of the outcomes, which is improving blood pressure control among patients with hypertension in US primary care practices. So first, I wanted to give a little background on Evidence Now. Evidence Now is a large agency for healthcare research quality funded initiative, and it funded 7 research teams that we called cooperatives nationally. These cooperatives provided external support, primarily in the form of practice facilitation to over 200, almost 250 primary care practices in their regions. And you'll see them here on the map. And sorry about that. Escalates was the national evaluation of Evidence Now, and I was part of that Escalates evaluation team, through which we learned a lot of generalizable lessons about what it takes to implement practice facilitation across so many practices. Now, each cooperative or research team conducted its own implementation research study that was aimed at demonstrating the effectiveness of practice facilitation and a few other external support strategies. The goal of the study was to demonstrate effectiveness on improving cardiovascular disease outcomes among primary care practices. Many of these used hybrid designs, effectiveness and implementation, such as cluster randomized trials, stepped wedge trials, and the unit of analysis was primary care practice, not patient. So we collected a lot of data at the practice level. The main outcomes of Evidence Now were the ABCS of heart health, aspirin use, blood pressure control, cholesterol management, smoking cessation. And some of these outcomes, in fact, have also changed. Now the guidelines have changed. So this is as of the time that the study was being implemented. And then importantly, in the middle was practice capacity. So the initiative was also focused on enhancing practice capacity through implementing practice facilitation and other external support strategies. So there was this explicit acknowledgement in the initiative that improving clinical outcomes, in this case ABCS, without addressing practice capacity would not necessarily lead to sustainable change, not just in cardiovascular disease outcome, but other outcomes, other clinical outcomes as well. And part of the reason there was this explicit acknowledgement from the funder was that these interventions were based in smaller primary care practices that typically do not have the capacity or the quality improvement support that is needed to continually make changes and improve care. So in Evidence Now, what we found was at baseline, when we measured the main outcomes here of aspirin, blood pressure, cholesterol, and smoking cessation support, that among these smaller primary care practices, which typically had less than 10 clinicians, at baseline, there was significant variation across each of these measures. And you'll see that here. For blood pressure, for aspirin, you have lots of practices that have fairly low percentage of patients who are appropriately on aspirin or have blood pressure control at 140/90, which was the recommendation at the time, and so on and so forth. So we were very interested in learning that variation from that variation. Why are these practices different from the ones that have higher performance on these metrics? And so this variation was our friend. We really needed to benefit from learning from all of these variations. So as I was saying, smaller practices in the US face many challenges in making practice improvements. They have significant time constraints, staff shortages, narrow financial margins. They have lower capacity to do improvements. And these issues have only gotten worse over time, especially because of COVID. And the premise was that quality improvement support for these practices can help them perhaps improve. And facilitation has been shown to be an effective strategy to improve delivery of primary care services in many studies. And so evidence now embarked on an initiative to demonstrate how to get facilitation to many practices at scale. Now, to illustrate the blending of quality improvement and implementation science, I'm focusing on the blood pressure quality metric. So JNC7 guidelines recommended blood pressure target of 140/90 for individuals with hypertension at the time. And in evidence now, a cooperative or research team used external facilitators as the actors to support practices in making improvements. This is the implementation strategy, right? And the facilitation involved interactive problem solving and support for quality improvement activities, as well as EHR and HIT support to measure outcome metrics at the minimum. The quality improvement interventions were implemented by clinic teams, where the clinic teams are the actors. And the practices implemented QI changes using iterative PDSA quality improvement cycles. And for the blood pressure improvement, what we observed was that the three most common quality improvements that were implemented at the practice level was training staff in appropriately measuring blood pressure, taking at least 2 blood pressure measurements in office, and documenting blood pressure measurements in discrete fields in the electronic health record. These were very important quality improvements that needed to happen because among patients with hypertension, we know that just 1 blood pressure in the office can, in fact, be inadequate to control and to work for other management approaches by the clinicians. And in this paper, what we found was that there was a combination of certain conditions and operational changes that was linked to improvements in blood pressure. First and foremost, these were purposely sampled practices and where we did interviews with practice staff. And we found that a combination of measurement training, taking repeat blood pressure, and documentation only worked when it was done among smaller practices that were physician-owned, and a high level of practice facilitation was provided to the practices. So we needed that combination of the implementation strategy along with the quality improvements that were going on in practices to make at least a 10-point improvement in the blood pressure clinical quality metric. And so in this case, the evaluation team's approach to measuring and understanding what is happening on the ground in primary care practices, as well as evaluating what is happening at the facilitation level, allowed us to glean lessons learned from the PDSA cycles, as well as produce generalizable knowledge around facilitation. So further, our evaluation allowed us to glean how facilitation helped build practice capacity. So not just that it works, but how is it helping practices themselves? And we were able to, through our qualitative analysis, look at or identify facilitators that were more effective in helping practices improve their outcomes and those that were less effective. And what I want to highlight is that the more effective facilitators really identified pain points through conversation with the practices and discussed next steps. They shared ideas from other practices, cross-pollination idea. They provided project management support. And contrast that with the less effective facilitators that did more didactic meetings or did work for the practice or sort of did education, presented options, but did not push the practice to identify next steps. So it really needed this level of helping practices learn how to do quality improvement to make real change. And so as you can see from this in fact also continued to help practices improve and build capacity towards doing more quality improvement. So I wanted to bring it back to the practice change model that drove some of our understanding, that drove some of our research. And I was kind of grappling whether I put the model first to explain it or later, but I put it later because I wanted to show this model that actually came from real research studies, and it's evidence, it's driven by evidence, where there are 4 key domains of how practices might change or why practices might change. That include motivation of key stakeholders, resources for change, outside motivators, and opportunities for change. And these are interdependent. They influence each other. So in evidence now, we saw that when leaders put value on cardiovascular disease prevention and practices had some of the resources for change, such as their quality improvement infrastructure, such as having a culture that allows for improvement, adequate staffing, EHR systems. When that was coupled with having payment models, effective facilitators, and external quality improvement support, that together change could occur. And together practice capacity could be built. So this model has been very helpful in continuing to blend quality improvement implementation research as we see change happening across many practices. This is another representation of how implementation science and quality improvement are blended in research. And this model comes from work that was done in practice-based research networks in Oregon across many studies. So they synthesize findings across many studies. And I found this to be a very useful way of looking at implementation science and quality improvement. And so as you see in the top part of the figure where it says START, implementation science really helps bring information and details about evidence-based interventions and programs so that we're working with good evidence, theories to inform the design process and evaluation, and systematic processes to describe, tailor, adapt the change strategies. But what quality improvement brings to the table is a process of interacting with practices that honors those lived experiences, the local knowledge, the local infrastructure, methods to balance and align interventions and competing priorities, tools such as PDSAs, model for improvement, which Dr. Ramaswamy will talk about, some rapid cycle methods, capacity development, that then keep the practices really engaged in the change process. And then implementation science helps close the loop again through rigorous analysis of implementation outcomes and intervention outcomes, as well as in evaluation and dissemination efforts and scale up, which evidence now was a great example of how this synthesis helped to generate lessons of how to scale facilitation and external support across the country. So the second example that I wanted to bring up was another initiative called Advancing Care Together that was focused on integrating behavioral health and primary care. And my role in this was as part of the evaluation team of this project. This was a foundation for a project that was based out of Colorado. As I said, the premise was that practices wanted to integrate primary and behavioral health care. We know that it improves clinical outcomes, patient experience, and it reduces cost. Yet real-world clinics at the time were struggling to integrate care, and I would say are still struggling in some cases to integrate care. In this study, we had 11 ambulatory primary care or mental health clinics that were all in Colorado. They came together with a small amount of funding, very interested in implementing evidence-based approaches to integrate care for people with primary care and behavioral health care needs. And the purpose was that we wanted to identify strategies to integrate care that could be implemented in real-world clinics that resulted in improved care delivery and outcomes, could also lead to generalizable knowledge, and could be rapidly disseminated more broadly. And so through this initiative, we try to achieve these 4 outcomes, 4 objectives. In terms of its methods, our evaluation was a longitudinal mixed methods evaluation. As I was saying, practices implemented evidence-based strategies that revolved around, and there were some smaller ones, but a systematic screening for behavioral health issues and co-locating behavioral health and primary care clinicians. We collected both qualitative and quantitative data in the form of diaries, field observation interviews, surveys, and EHR outcome data. And in our analysis, we did extensive merging of qualitative and quantitative data and using grounded theory, immersion crystallization, and also mixed effects models. I'm not going to present all of the results from this initiative, but really what I wanted to focus on was our approach to evaluating advancing care together, which we called it the learning evaluation. And I can walk you through this diagram here, where each of this represents an organization, a primary care practice that was in our evaluation, in our study. And the infrastructure around it is the evaluation team, is how you can think of it. And the way we structured this evaluation was that we wanted to have the opportunity to learn from these small cycles of change, which were pretty rapid, but very focused on specific quality improvements that practices wanted to implement. We wanted to bring the practices together in a learning meeting to reflect on those changes, what's changing, what's working, what's not working, and then go back and try another EDSA cycle, come back. And so we did these learning meetings every 3 months across the project for each organization. So across each organization, then we also built an infrastructure for data collection. We collected mixed methods data. Our team synthesized the qualitative and quantitative data within and across these practices in real time. And we provided feedback in these learning meetings through established methods in quality improvement, such as process charts, run charts, but integrating that also with key events and quality improvement successes and challenges that they might have experienced along the way. And it was done to really stimulate learning and improvement. Through this process, we found that it benefited practices a lot. It did improve outcomes, and all of those data are published. But what is really most important, a lesson for us, is that we think it reduced the translational timeline, because we were doing this approach of not only evaluating what's working and what's not working for writing a paper, but we were also feeding it back to the practices so that continuous change could occur over time, and therefore then reduce the translational time for actually changes to take into effect. This slide, these are our organizing principles from the learning evaluation and advancing care together that I wanted to show, because not for the details that are in each of these rows of the table, but that this was a way for us to generate practice-based evidence. And so we're very familiar with evidence-based practice and all of the approaches to generating evidence-based practice, but Lawrence W. Green has written extensively about also generating practice-based evidence. And it is this knowledge, local knowledge generated from practice, that is so essential to also help improve our understanding of how to make changes, and then also how to produce generalizable knowledge. So he said it, and I will be I will obviously follow that. But in my work over all these years, generating that practice-based evidence has been very, very important to keep practices engaged in the research, for practices to benefit from the research, and also to build capacity. Some of the limitations in advancing care together, which I put with a question mark, is to just be a little provocative to say it was a non-randomized study, but we generated practice-based evidence. And it was a fairly small practice sample size, but it was a maximum variation sample, which I didn't go into details, but we had practices that were small practices, large practices, primary care, mental health, but that maximum variation sample allowed us to study and understand these unique differences and similarities. Perhaps not generalizable, but definitely lessons learned are transportable. And a lot of work in the primary care space has also written quite a bit about transportability. that I find very useful in thinking about the producing generalizable knowledge, that another aspect of generalizability is also whether intervention can be transported to other settings, and what do we need to know to transport that. So in summarizing then, how can researchers blend quality improvement and implementation science? And I tried to put together some of my thoughts as well as what I've been reading in the literature. Both in Advancing Care Together and Evidence Now, we partnered with practice members, policymakers, researchers, really need to go to interested parties right outside of academia. I think there's a real need for co-producing interventions. In implementation research, we're talking a lot about stakeholder engagement, user-centered designs, and all of those things are important, but truly co-producing them with our partners, with the people and the systems where we're implementing them. Working in transdisciplinary research teams, which I won't go into too much because I think we all understand that, but also implement together. I think the learning evaluation, some of the criticism we were getting around the learning evaluation was, are you contaminating the intervention? Yet the ability to evaluate and implement a little bit together allowed a relationship between the implementers and the evaluators that then helped with continuous quality improvement, change with support, and improving practice capacity. Conduct rigorous mixed methods evaluations is very, very critical for this kind of work. I'll add two more to this, which is pay attention to conventional wisdom or basic good practice. I think Dr. Ramaswamy may hit on this topic a little bit more, but the idea that evidence-based interventions, or what is evidence, comes only from research is something that we can push back on. There are some conventional wisdom and basic good practice that could also be considered good evidence to implement. And all of us as researchers, I think, would help if we thought before creating new ways to push research into practice, and also account for the pull of practice and what practices really need to improve care quality. And I'll end with this quote, which is, to him who devotes life to science, nothing can give more happiness than increasing the number of discoveries. But his cup of joy is full when the results of his study immediately find practical applications. And I think all of us who do work in this space of bridging research and practice, this quote really resonates. So thank you for your time, and I will hand it off to Dr. Ramaswamy for talking about global primary care settings.
Thank you, Dr. Balasubramanian. Can I, okay, I'm still seeing, are you seeing my slides? Because I am seeing, let me try again.
Dr. Ramaswamy.
Okay, no, I think I'm sharing your slides instead of mine.
Yes.
Okay, that's what was happening. No wonder.
I think I stopped sharing.
Okay, perfect. Okay, this should work better. Are you seeing mine now?
It is just coming up. Give it a second.
Okay.
It says has started screen sharing.
Yeah, I don't see it my side. It says it's my screen sharing is paused. Let's see, resume share. Let's see if that works. Okay. We tried this and it worked when we were doing it in.
Yeah, our test run worked okay.
Yes. Let's see.
Oh, it's again my slides.
Okay, well, let me try something. Let me try closing out here. For some reason, I may have both things open. And okay, this will work. Oh. How does that look now?
Yes, perfect.
Wonderful. And I'll bring it to slideshow mode. Okay, third time's a charm. Thank you very
Great.
much for that great presentation. And thank you for your patience as we were trying to get our technology under control. Dr. Balasubramanian and I did not formally coordinate our presentations, but you will see in what I'm talking about a lot of similarities between what she talked about in the US settings and some of the examples that I'm going to provide from the global settings. And I come from a different background. I was trained as an engineer. My PhD is in systems engineering. And I come to this field from many years of experience in quality improvement, working in the in industry setting. As Dr. Balasubramanian said, originally quality improvement came from manufacturing and service industries, and I've spent a lot of time developing large-scale QI programs. And then what was apparent, and this was apparent in the quality improvement initiatives, even in industry settings, was that ultimately a lot of the good ideas that were generated as a result of the QI efforts were not implemented. And so over the years, as I've begun to do quality improvement work in healthcare settings, and I began to get more interested in implementation science, it became apparent to me that even though these two fields had grown up differently, and even though these two fields come from different backgrounds and sources, they really need to work together in a way that allows us to be able to benefit from what each of these fields provides. And so for the last 4 or 5 years, a lot of my work has been in formally working on integrating these two fields so that we can, and my global health work is both on the research side and the practice side, is in helping organizations think a little bit about how they can use these two fields together so that they can not only implement what they are, the kind of evidence that they're generating, but they can use quality improvement to generate the right evidence. And that's what I'm going to be talking about today. And so I'm beginning more or less in the same place where Dr. Balasubramanian began, which is what we're looking for ultimately is neither to come up with improvement solutions for improving and evidence for improvement, nor are we looking just to think about how can we implement what we already know. What we're looking for, if we think about being successful at some of the complex problems that are facing us in the healthcare and public health domain, it's really about transforming systems. We have to be able to get to the root of why things are not working the way they should. And therefore, how do we begin to think within a particular context, within a particular environment, within a particular setting, what kind of change needs to happen so that we can achieve outcomes? And as we begin to think about how to do that, we see that this is not just neither about implementation, nor is it about solutions, but it is about both of them together. And so what you see on the slide is, I think of it as, you need the seeds, you need the right seeds, but it's not enough just to have the seeds. You also need the farmer who sows the seeds, who waters the seeds, who tends to the fields, so that you can get successful outcomes. And I think about the quality improvement side of the field as kind of thinking about these change solutions. What are the right ingredients for me to be successful? And then the effective implementation is, how do I make sure that those ingredients are actually instantiated in my setting in a way that allows them to generate the greatest results? And so you will see, as I go through my examples, how we are explicitly using the QI model and expanding it to address implementation issues as well. But before I do that, I want to step back a little bit and reinforce some of what Dr. Balasubramanian said in her presentation, which is about, when we think about evidence, what do we actually mean by evidence? Certainly, the implementation science field has focused on evidence-based interventions. And often we come away with a sense that there is some body of knowledge that says evidence-based intervention, we can pull it out of our pockets, and all we need to do is to use implementation science methods to implement. But in reality, if we're working in practice settings, it's not just, yes, we certainly do want to be thinking about what has come from research. We want to make sure that we are not arbitrarily implementing things that we have not tested. But when we think about testing, there are many different ways in which we can think about evidence. So certainly there are research interventions, but we want to be able to think about, what is it that the clinicians know through years of embedded wisdom? What is it that the clients prefer, especially when we're getting to think about from an equity perspective? Are we coming up? We might have the best evidence for certain interventions, but they may not be appropriate for the particular context. What do we know about the organizational culture that defines whether certain interventions are feasible or not? And so as we begin to think about how are we going to be successful in particular settings, we want to think about the evidence more broadly. We want to think about these as chain solutions that blend what we know from the evidence, from the research evidence, with what is known on the ground. And the question is, how do we do that in a systematic way? So that's one side. On the other side, on the implementation side, we need to be able to think systematically about how to implement. So we need to be able to say, it's not just I am generating this evidence and I'm going to throw it into my organization and it's going to magically result in outcomes, but I have to be able to guide the implementation process using what we call implementation strategies. So these are methods or techniques to enhance the adoption, implementation, and sustainability of an intervention. And essentially, because of the way quality improvement and implementation science have existed and grown up as two separate fields, there has been always a wall between, on one hand, the assumption that I need to be able to generate local solutions because those are the only ones that matter. But on the other hand, that somehow these evidence-based solutions come to me and I need to be thinking about how do I put them into practice in my settings. And what I'm going to talk about is that this wall is artificial. This wall does not exist. What we really need to be thinking about is, if we break this wall down, what do we get? And how do we use the fact that we actually have now these two fields that can work together to produce the best results? Just to be kind of clear in terms of what we're talking about with respect to the intervention and the evidence-based intervention, the evidence, and the implementation. This is a slide that Jeff Curran has put together that I use a lot, because there is a lot of confusion, especially amongst those who are not implementation scientists, between what is the intervention and what is the implementation. And so just to be clear, just to get our terminology clear, we think about an intervention and practice innovation as something that has come up either from our quality improvement efforts or through research or through both. And so we have done some effectiveness research that says either as a result of QI processes or as a result of research that says this thing that we have is promising, it has been demonstrated to work. But then we need to be able to think about, how do we help people do the thing? And so implementation strategies and implementation research allows us to be able to say, what are the kinds of things that we need to do to take this thing that has been known to work and put it into practice? And the question is, how do we do this together? And how do we do this in a way that can jointly optimizes both our evidence that we're generating and the implementation approach that we're using? So from the implementation research perspective, the idea of being able to blend the evidence-based intervention and the implementation has been described in terms of these hybrid trials. Dr. Balasubramanian talked about the hybrid type 3 trial. And for those of just in terms of a quick introduction, from hybrid 1 to hybrid 3, we give different weights to the effectiveness of the intervention itself relative to the effectiveness of the implementation process. So a hybrid type 1 has a primary focus on the effectiveness of the intervention. And then we might do some follow-up evaluation to understand barriers and facilitators to implementation. A hybrid type 2 provides equivalent weight to both the implementation process, understanding how implementation results in outcomes, but it also places an equal emphasis on outcomes. A hybrid type 3 has a particular focus on the implementation strategy itself. It might test multiple implementation strategies to see what particular strategy works, and then to be able to say, what kind of implementation outcomes does it achieve, and how do these implementation outcomes achieve the health outcomes? So I wanted to show this, just to get a sense, to give you a sense of the fact that while these general hybrid trials form the basis and the framework for the research that we do, we still have to be able to think about what is the thing and what are the things and how do we test and study and do the thing and how do we gather information on the thing. Each of these, while there's a lot of literature on hybrid trials themselves, how do we gather the evidence to do a hybrid trial? How do we set up the implementation strategies? How do we learn from these implementation strategies so that we can kind of continue to improve the quality of the interventions? These are things that the hybrid trial design, we were still learning. And so some of the kinds of things that I'm going to talk about through our examples is how do we do that? And so when we think about the intersection between these two fields, the other set of issues that face us is that, as Dr. Balasubramanian mentioned, we do need to know what works in different settings. We need to be able to engage practitioners in the knowledge that they know from the work that they have done in various contexts. And so it's not enough for us just to say, does something work, which is a reductionist question, but we also want to be able to answer questions around when does it work and where does it work and for whom does it work and what must be done to make it work? How do we tailor and combine solutions? And we cannot do this without some kind of a learning approach that takes basic internal data and experience and integrates it with external evidence. And this cycle of integrating local knowledge with external evidence is what we call a learning health system. And the integration of quality improvement and implementation science allows us to be able to develop a learning health systems from which we can learn about what works and we can learn how to implement what works in a way that fits the local context. And so as we have been studying over the last 5 years about how to do this, what we have actually done is we've created a formal model that we call the model for improvement and implementation. And the model for improvement and implementation breaks down this wall between the two fields that I talked about earlier. On the left-hand side of this model is the traditional quality improvement model, the model for improvement, which is used in healthcare settings extensively around the world to look at improving clinical outcomes. And what we have are the 3 questions that come from the model for improvement. What are we trying to accomplish? How do we know that it changes in improvement? And what change can we make that will result in improvement? Using the model for improvement allows us to be able to generate local evidence and to be able to blend that evidence with what else is known from the research and use the plan, do, study, act cycles to come up with an intervention that is the right fit for the context. So the evidence generation process comes from the left-hand side of this model. On the right-hand side of this model are the implementation questions. And those of you who are implementation researchers will see that these questions correspond to some of the terminology that we know from implementation research: implementation outcomes, implementation determinants, and implementation strategies. Well, we've not used those words explicitly here, but the first question says, what implementation outcomes do I care about? Second question says, what are the determinants that affect these achievement of these outcomes? And the third question says, what strategies do I need to use to address these determinants? And so on the right-hand side, we have the questions that say, what are the kinds of things that I need to be paying attention to in order for me to implement the evidence that I've generated from the left-hand side? The PDSA cycle is kind of the workhorse that binds these two sides together. Because just like I need to do the PDSA on the left-hand side to be able to adapt my intervention to the local context, I need to be able to do PDSA on the right-hand side so that I can come up with the appropriate implementation strategy that fits my context. And the other thing is that if you see the linkages between the left-hand side and the right-hand side, I can start from the left. So I can start with generating evidence, and then I can think about how to implement that evidence on the right. Or I can start with the right. I have something that I need to implement. So I'm starting with these implementation questions, and something that I need to implement might come from my knowledge from other sites. This is what the transportability that Dr. Balasubramanian talked about. I may transport a solution from somewhere else, and I might need to implement it in my side. But then as I'm implementing it in my side, I am finding out that I need to tailor and adapt the evidence better so that it's a better fit. In which case, what I will need to do is I'll need to start on the right-hand side of the model and move to the left-hand side so that I am beginning to think about how do I adapt my intervention for better implementation. And so by using this model iteratively from the left-hand side to the right-hand side, what I come up with is a mechanism that allows me to be able to select the right intervention for the right context and implement it in the right way, but using PDSA as a learning tool. So as Dr. Balasubramanian talked about the learning evaluation, I don't know for sure when I enter a site what either the right evidence is going to be and how it is going to be adapted, nor do I know what the right implementation strategy is going to be. But using this model and using this learning evaluation approach, I am able to kind of do a sequence, iterative sequence of testing that allows me to come up with an optimized solution. So this is the general framing for the work that I have been doing globally. And I'm going to provide two examples for how we've been using it. And just like Dr. Balasubramanian said, the two examples that I'm going to present, the first example is to show how we've used quality improvement as an implementation strategy. And the second example I'm going to show is how we are using the model for improvement and implementation that I talked about earlier as a way for strengthening the system, for generating local evidence, and then for implementing it. So the first, in the first example, the Essence implementation trial is a trial in India. And it is a trial that seeks to integrate depression screening into the primary healthcare system. So it is integrating behavioral health with primary care, very similar to the example that Dr. Balasubramanian mentioned. And so what the study hypothesis is that in order for us to be able to do that, in order for us to be able to effectively implement an evidence-based intervention around depression screening into existing primary healthcare, we're going to need to have some kind of implementation support, some kind of coaching that will allow the primary healthcare centers to identify barriers to implementation and to solve these problems that allow them to implement better. So this is a type 3 hybrid trial. It's a 2-arm parallel cluster randomized trial where one arm is what we call an enhanced implementation support arm. And then one is the control arm, which is the routine implementation support, which is basically what the primary care centers currently do for NCD implementation. So there is no additional support, there's no problem solving, there's no coaching. So the enhanced implementation support uses a formal protocolized model for implementation to provide coaching to address implementation issues. And so we use the model for this is the right-hand side of the model that I showed earlier, because we're using a quality improvement type approach, which is 3 questions in the PDSA approach, as a problem solving, as an implementation strategy to solve implementation problems, to use PDSA to learn about these implementation problems, and then to work with the teams to address these problems. And so the way that the implementation support intervention works is we've got these one-on-one remote technical assistance sessions. This is where the coaching takes place. It's the 45-minute sessions where the coaches use the model for implementation to systematically look at implementation issues and to suggest PDSAs that the intervention arm facilities can do to address these issues. Then what we do is once every few months, the facilities that are the intervention arm come together for learning sessions. And through these learning sessions, they learn what has been successful in other facilities, and they use the learnings to try out their own PDSA cycle. So it accelerates the pace of knowledge. So as Dr. Balasubramanian said, what it does is it reduces the translational time. So things that are known in other facilities are tried more rapidly in the new facilities. And together, therefore, this improves what we know about implementation. And then, of course, to support all of these so that there's ongoing conversation, ongoing coaching, there's a WhatsApp platform that links all these facilities together. Here's the coaching assistant, the fortnightly technical assistance coaching flowchart. So the flowchart is protocolized. So what we've done is we've taken the model for implementation questions and we've created a coaching protocol. This doesn't necessarily mean that the coaching protocol is rigid, that there's only one way of coaching. But what it does is it provides the coaches a way of saying, how do I implement this model in a way that allows me to learn? What are the different, how do I look at data over time and what I know about the way implementation is proceeding in each of these facilities? And how do I use my historical knowledge about how implementation is proceeding to ask the next set of questions so that I can generate the next set of PDSA cycles. So in this particular case, we have used some of the key components of QI, small tests of change, collecting data over time, learning as we go, understanding local context, and use this QI approach through the model for implementation to generate a coaching protocol that allows us to be able to support a set of facilities to implement better. Where we are with this trial is the trial is just underway. It'll end in the next few months. But we also have just like Dr. Balasubramanian had, we have an extensive process evaluation framework around this that I'm not sharing today that allows us to be able to evaluate the implementation process. So that is one example. This is where we used, as I said, QI as an implementation strategy. The second example that I'm going to share is where we're jointly using quality improvement and implementation science for system strengthening. And this is an example in Ghana. This is a project called MEBC, Making Every Baby Count. And the objective, there are 4 objectives of this project. Basically, in summary, it is to strengthen the system of tertiary care. So this is not a primary care example, it's a tertiary care example. But because this is a low resource setting, the idea is that the tertiary care centers that provide advanced maternal neonatal care still do not have the systems and supports and structures that are needed to be able to deliver the kind of care that is needed for sick newborns. And so we are using a combination of quality improvement and implementation science to strengthen the overall system. We're doing this in 4 tertiary care hospitals in the country, 2 of which are the facilities that have the highest volumes and that get the most advanced cases. And so strengthening the system consists of 3 different areas. It consists of strengthening clinical excellence, which is making sure that the healthcare providers, the NICU nurses, and the neonatologists have the best clinical expertise, the best clinical knowledge. Then we have operational excellence, which is making sure that the barriers to implementation and the delivery processes that need to be strengthened in order for the clinicians to be able to do that work, which is very local, that we identify and understand where improvements need to be made. And then finally, this idea of leadership excellence, that ultimately we are going to need. This is not just about having the right processes and the right training. That overall, what we need is a problem-solving mentality. This is where the system transformation piece comes in. We need to have leaders who are committed to making sure that they are supporting the system to improve the quality as well as to implement, and that they are trained appropriately to be able to understand how we are using QI and implementation science together so that they can support the implementation. And so the way that we do this is by kind of 3 different types of training. We provide what we call foundational training that allows us to be able to come up with that allows us to be able to train coaches to support the implementation process. We have the clinical training, as I talked about earlier, that is done by the American Association of Pediatrics that provides the best change solution. So this is the understanding kind of what the best practices are around neonatal care and how these best practices, you can use QI approaches to translate and adapt these best practices for the context. And then we also set up an infrastructure for data, making sure that there's the right equipment, and training the leadership to create the enabling context. And these 3 things together are intended to provide improved organizational capability to deliver care and to reduce perinatal mortality. And so this is our coaching structure. We have multiple levels of coaching. The particular coaching structure that I'm going to focus on here is how we build we've identified a set of coaches who we call quality improvement and implementation coaches. And these are the coaches that we are training using the model for improvement and implementation to jointly provide coaching on both the QI side of the implementation process and on the implementation side of the implementation process. And so what does that mean? We say that we are training these coaches to do coaching for improvement, which is there are certain situations where we might not know what we need to do in order to implement better. There may be places, for example, where the clinical knowledge where the trainers have provided the clinical knowledge, but that clinical knowledge needs to be adapted for fit within the particular setting. It may be that there are certain processes for service delivery that do not exist. A case in point is where babies get transferred, for example, from the labor ward or from the OR after cesarean section into the NICU. But the process for transfer so that the babies are kept warm and the process for transfer so that the transfer takes place in a timely manner does not currently exist. And so what we really need to do is we need to be using quality improvement methods to be able to take either evidence that is known elsewhere about how this transfer process works or to generate local evidence. So that's what the coaching for improvement is. And then coaching for implementation is where I know that there are particular solutions. I know certain things need to be done. But as Dr. Balasubramanian said, the organization is not doing it. We need to be able to change knowledge. We need to be able to change attitudes. We need to be able to change perceptions. And therefore, how do we begin to use the implementation science approaches to develop implementation strategies to be able to do that? And so we train these coaches to do both. And so they can either be an improvement coach or an implementation coach, or depending on the particular circumstance. So if I need to address procedural or protocol issues, I put on my improvement coach hat. If I need to address behavioral and cultural issues, I put on my implementation coach hat. And then what we are supporting these coaches to do is to coach the implementation teams, which are the teams that are providing the clinical care across a variety of different projects. So we call them either quality improvement projects. These are projects that are more focused on the left-hand side of the model for improvement and implementation, where they need to be looking for solutions. Or we call them just do it projects, but these are projects where we actually know what the solution is, but the solution is not being implemented for some reason. And so here is where we use the right-hand side of the model for implementation, to be able to think about barriers to implementation. And so again, just like in the India project, we have a protocol, and the protocol takes a coach through a series of questions that helps them to determine which side of the which side of the model for improvement and implementation are you in right now? What is the pathway do you need to take? So for example, in this protocol, they first ask, does a change solution exist? If a change solution doesn't exist, we go through, use the model for improvement to find a change solution. Then we test the change solution. And once we test the change solution, we need to implement it. That then takes me to the model for implementation. And I am now asking the implementation questions. And once I come up with an implementation action, then I need to come back and I need to test the implementation action. And if my implementation action doesn't work, then I might need to go back to this loop to think about a new change solution that then can be implemented better. And so it's this kind of dance, this interplay between this improvement and implementation that we train the coaches to do. Where we are with this particular project is we have implemented in out of the four hospitals, the implementation is complete in 2 hospitals. And just like we talked about in India project, we have these learning networks that allow learning from one of the sites around implementation to be transported to other sites. So things that we have learned in one site, the idea is that we might use implementation, the model for implementation, to implement these learnings in the new sites. But there are things that we don't know in the new sites that we still need to discover. We still need to work with the care team to discover, and then we will use the model for improvement to be able to discover those things. And again, as we found in India, in Ghana, we are finding that the rate of knowledge increase around how to care for sick newborns is increasing rapidly through this process. Our process evaluation is showing that barriers to implementation are being fixed faster. We still have an external evaluation structure that where we are looking at the ultimate outcomes, which is neonatal mortality and neonatal morbidity, and that the evaluation will be completed in a year or so. So we have not yet been able to link this work that we've been doing in providing this kind of implementation support to what impact it has on the outcomes. But at least from the process evaluations that we're doing, we're demonstrating that not only is it increasing the pace at which changes that are happening within these facilities to support implementation, but also the knowledge and skills and problem-solving abilities of the frontline staff is increasing. So this is not simply about what do I need to do in order to implement MEPC2. Of course, I mean, that's the focus of the project, but what it allows is them to be able to do is say, how do I address these kind of systems issues in other contexts? Because this is not the only context in which I have processes that need to be designed. This is not the only context in which I need to change behaviors to implement evidence-based interventions. So it allows for knowledge about system strengthening that allows for the entire organization to function better. So let me end as well with a quote. This is from a paper that we had written a few years earlier. Integration of systematic implementation of quality improvement approaches is likely to enhance the quality of healthcare delivery by increasing the ability of practitioners to improve as well as to implement well. And this comes back to what I started with. Ultimately, what we're looking at is systems transformation. And by being able to bring together quality improvement implementation science, we have a greater probability of being able to transform systems the way that we want them to. I'm ending just to bring our two presentations together with the same slide that Dr. Balasubramanian presented. And I'm not going to, I think the points that Dr. Balasubramanian made are very similar to the ones that we have learned as well. Co-producing interventions, absolutely critical. Rigorous mixed methods evaluation, all of our programs have that built into it. Implementing together. So this is not really something about, so we have explicit teams where we bring together leadership and the doctors and the nurses together in hierarchical systems so that they can work together on implementation. Working with the government in each of these cases. So we have, I've not talked about it, we have technical steering committees and technical committees that partner these facilities with the government, with the Ministry of Health, so that some of the issues that are raised with respect to implementation can then become part of policy decisions that the government makes. So all of these different ways around using quality implementation science together allows us to be able overall to be able to create both a generalizable understanding of how to improve better, but also to strengthen the system so that we achieve better outcomes. Thank you for listening to me, and I'm hoping we have about 15 minutes for questions. And I'm going to stop sharing.
Thank you, Rohit. And I'll try to also facilitate the Q&A a little bit here. And I think perhaps go with the question, the last two questions that came up real quick, because they both have something to do with resources. So one question is, has staffing limitations affected your ability to make changes necessary? And the other is, iterative problem solving seems to require time, which is the most valuable and scarce resource in healthcare. How do organizations overcome the challenges of finite time and seemingly infinite work responsibilities when implementing these iterative problem solving processes? So I thought that, Rohit, you can take a stab at it and I can add my 2 cents as well. Oh, you're muted, Rohit. Okay.
Yeah, the staffing limitations have certainly affected our ability to make the changes necessary. And not just staffing limitations in the sense of staff not being there, but in both in Ghana and in India, because we've been working in government systems, the staff get transferred at will. So what might happen is we might just train a bunch of coaches, and then next month we might find that they get transferred somewhere else. And because in those other facilities they go to, they've not established infrastructure from the ground up. So all of the training that they have learned, that we've given them, and the skills that they've learned they're not able to put to good use. So one of the things that we've done in Ghana has been, as I said, we have this strategic advisory committee, which is a set of government, they're policymakers, the Ministry of Health, who are able to influence policy. And so we have raised this issue of staffing limitations to a strategic advisory committee to come up with policy changes that will allow, for example, people who we have trained to remain in facilities for longer periods of time, or if they are actually transferred out, to be able to see if they can use what we have learned to be able to build up quality improvement and implementation science programs in the other facilities. And so that has been taken up by the Ministry of Health in Ghana and is likely to be enacted in some way. So that's that is hopefully will mitigate our challenges with staff limitations. The second question around, yes, absolutely, the iterative tests of change do take time. And that is kind of an ongoing issue that we face in these facilities. However, the idea is that part of what we are, the value that ultimately the healthcare workers are discovering as a result of the work that we're doing with them is that it prevents rework. It prevents them having to fix errors. And so we are very careful, the coaches are very careful in prioritizing only the things that are most important. And the coaches are very careful in making sure that they are not asking for more time than is necessary, except to do things that really are needed in order to make sure that they're focusing on the things that affect the life of babies. So trying to be kind of transparent, trying to provide clear communication about why these iterative tests are important, and making sure that we're minimizing what is seen as a waste of time is something that needs to happen all the time.
Yeah, I appreciate that. I think we've found that correctly identifying the pain points of primary care practices and healthcare organizations is really important, and to factor that into the change process, the intervention. So be responsive to the needs when we are recruiting practices. And in fact, in Evidence Now, we often talked about the fact that we are not recruiting practices, we are engaging them, or we're partnering with them. And really the premise underlying that is that we're here to help improve capacity, to add value to your practice. So much of it is in that transparency that Dr. Ramaswamy just mentioned. And then also, it's obviously not the first time we're stepping in. I think there is a partnership building going on behind the scenes for a long time with many of these organizations that we work with. In Evidence Now, each grantee organization really had a long-standing partnership working with their practice-based research networks and other kinds of practices. And we found that prior relationship mattered, and mattered in a big way. I think when practices and organization felt burned by researchers, and I think I alluded to that a little bit, where our organization are used as participants in research, that's when some of those resource challenges and barriers come up a lot more. So in implementation research, the idea of quote unquote stakeholder engagement is an important one, but I think really bringing those aspects of transparency and the intent of helping build practices, build capacity and add value, I think is something we need to be thinking about a lot more. And that has helped in our research mitigate some of those challenges. There's another question here about from a person who is a D&I facilitator, who says, much of my job is consulting with researchers about how to incorporate dissemination implementation concepts into study designs. But your findings suggest that unless I mix some classic quality improvement techniques into my advice, it may not get researchers where they want to go. Is that accurate? And if so, there are so many brands of QI, how do I explore them all? Maybe I can take that person, then you can go, Rohit.
Yeah, that sounds good.
That's a great question. I think from the point of view of transforming systems or making transformative system change, I would say yes. Where it seems appropriate, you should try to mix and incorporate classic QI techniques into the work of a dissemination implementation facilitator. However, which ones to explore and which ones to use, I think implementation research, in fact, gives you a toolkit to do that. If you use an appropriate model for improvement, a theory framework to guide what is the change that you're trying to have, and Dr. Ramaswamy's examples really showed that may help you get down into which ones make sense. In Evidence Now, we spent a lot of time talking about what is the black box of practice facilitation. It's a meta implementation strategy with lots of different components within it. They could be facilitators helping make sense of audit and feedback data, or facilitators actually helping form a quality improvement team and coaching the practices into how to do a PDSA, what should be the target of a PDSA. But that needed to be driven with a model or a conceptual framework around what is the target of the change that we're trying to do. And I found that Dr. Ramaswamy's example of coaching for improvement versus coaching for implementation, and the two sides of the model as a very useful thinking tool to make decisions or assessments about what brands of QI might you explore.
Yeah, thank you, Bijal. This question about many brands of QI is kind of similar to the question around, what's the difference between quality improvement and implementation science? QI itself, there are people who are, who have their favorite brands and therefore they stick to them. What I have tried to do, and I really like the way that you've phrased this question, because you're talking about mixing some classic QI techniques into your advice. And so what I tend to do is not to walk down the path of, okay, am I doing Six Sigma, or am I doing Lean, or am I doing the model for improvement? Instead, I kind of think about this as a toolkit. And so rather than getting hung up in the brands, I will do a few things. Process mapping. It's really, understanding what your process is, so that you can understand where in the process there might be implementation issues. It doesn't matter which brand of QI you're using, it's always useful. Something like a theory of change, as Dr. Balasubramanian mentioned. So whether it's a driver diagram, something that says, what is my outcome and what are the drivers of my outcomes? Doing something like root cause analysis, like a 5 whys, that helps me to dig a little bit deeper to get an understanding of where there might be, of how I might, where I'm going to kind of target my implementation and improvement efforts. PDSA, irrespective of whatever method I'm using, small and iterative tests of change, process measures and process evaluation. So what I tend to do is to go therefore with my kind of classic QI toolkit rather than my kind of classic QI brand. And ultimately, when you study the brands, all of them do the same thing. They just have different language. And so I try not to kind of get down that path. But you're absolutely right. These 4 or 5 different tools, if you can bring them into your D&I facilitation work, they significantly enhance the capability of what you can do with the D&I and the D&I side.
That's great. I think we have just one other question, which is, when choosing your study, was there a needs assessment done to identify that there is a problem?
For the 2 global health projects, absolutely.
Yeah.
I mean, yeah, the both of them are designed to address very important problems that are as yet unsolved.
Same with the studies I described. And while I may myself have not done the needs assessment, extensive work was done to understand what are the challenges that are facing primary care practices in both Advancing Care Together and Evidence Now, that then supported the selection of the change processes and everything else. Absolutely. Okay, we still have time, so we'll keep going. There's another question that just popped up. Can you please share your thoughts about coaching/facilitating? What are key points when planning coaches training, evaluation, monitoring? How much time and dollars are needed?
I can talk about what we have done. So it is a good question. Being able to bring coaches up to speed in a way that allows them to be good problem solvers is a time-intensive, labor-intensive process. What we have done in both of our projects is that we've minimized the time on initial training for obvious reasons, and which we discussed earlier. All of the coaches are also they're healthcare providers, and so it's important not to kind of take them away from the work that they're doing. So our training was limited to 3 days in India and 2 days in Ghana. But then what we have what we did in what we've done in both these sites is we have, over a period of 6 months, we have once a week meetings. And once a week meetings is that our research team then serves as master coaches to the coaches themselves. And so we do kind of like we provide coaching support to the coaches where they raise issues and we discuss them collaboratively. And that has been, we've done that for 6 months on both sides, and that has turned out to be very useful because it allows the coaches to be able to talk. So we're not just focusing on the training, we're talking about the practical issues that they face. And that at the end of 6 months, we have found that we are able then to let the coaches go on their own. And in some of the sites, like the Ghana sites, the coaches that we have then trained as the coaches in the first site, because this is a sequential implementation, are now serving as master coaches for the later sites.
Yeah, and in US settings, and specifically in the Evidence Now project, where there was significant interest in understanding facilitation and aspects of facilitation, practice facilitation to improve capacity. Many of those organizations and grantees leveraged AHECs, Area Health Education Centers, that occur or exist across the country that have a facilitation workforce. But in addition to that, they also leveraged some of the training approaches that are available through the Institute for Healthcare Improvement and some other organizations that provide that. Now, yes, it is definitely time consuming and requires some dollars, but in projects where facilitation of that intensive nature, such as what was in Evidence Now, were needed, that kind of training was invaluable. And you saw, to some extent, you saw that in the slide I presented about the more effective versus the less effective facilitators and the importance of training there. The one other thing I wanted to say was that, which I alluded to, but Evidence Now is really about what is a model for scaling and providing external support through facilitation to lots of smaller primary care practices who need it. And so there's a lot of policy level conversations also going on about what does this facilitation workforce look like for the country if we go down this path? What are the aspects of facilitators that we need? So in some respects, I think of it like the workforce we have for community health workers. And sometimes and often community health workers can also serve as facilitators for primary care practices in some regions. And we've seen models, for example, in New Mexico, where community health workers and practice facilitators are kind of one and the same, but do two jobs. So there is quite a lot building both on the policy and the research side around what is facilitation, how to train facilitators, and some training models around it. But I thought that would be helpful. And the last thing is Agency for Healthcare Research and Quality has, for primary care practice facilitation, quite an extensive handbook for training that you may want to look into.
There's a question about recommending additional training sources and intersecting QI-IS approaches. I'm happy to provide some additional resources, and I think what we'll do is we'll pass them through through Ricky for circulation.
Yeah, and in my slides, when the slides are put up towards the end, and perhaps in yours too, there are some curated papers that I put in that talk about this intersection and all of the issues. So that also should help you get going.
Yeah, I forgot to add them to my slides, but I'm happy to supply.
Yeah, no, that's all right. All right, we're like right on time, Ricky.
Yes, amazing. Thank you both so much for the wonderful presentation, and thanks everybody for attending today. You should see in the chat where the link to the recording and slides will be, but we'll also be sending it out via email when it's posted. I'm going to also put the link to the registration for our last event next week, the Implementation Science and Health Equity panel that will be happening on the 7th. So please join us for that if you can. And thank you, Dr. Ramaswamy and Dr. Balasubramanian again for the wonderful presentation today. And thank you all for joining.
Thank you. It was
Thank you.
Bye, everyone.